First of all, I want to make sure, can everyone hear me?
Yes.
Okay. Thank you so much for that introduction, Dr. Jindal. And before I begin, it's a pleasure to return to Ottawa. This is where my roots are. And Dr. Jindal may or may not remember this, but and this is going to seem ironical because this is a sleep lecture. Myself and a small group of other medical students fell asleep in Dr. Jindal's and it was not because it was boring in any way. We were sleep deprived because we were on call the night before.
Lecture was soothing.
Yes, exactly. So this quotation here, an equation means nothing to me unless it expresses a thought from God. That is a quote from the famous mathematician Ramanujan. And can anyone tell me what Ramanujan was doing when he formulated his famous mathematical theorems, his Mach theta equations? He was sleeping, exactly. He was sleeping. And more than that, he was dreaming. He was divinely inspired, he said, by the goddess Lakshmi to formulate these theorems. And throughout history, there are many, many great thinkers who were inspired by sleep. Einstein was inspired by getting a good night's sleep. I was inspired to give this lecture by having a good night's sleep. So we're going to talk about basic sleep health. What I would like to do is keep this portion as short as possible, the didactic portion, so we'll have ample time for a Q&A session. Okay, so moving along. First of all, I have no affiliation with any private industries. I work in the federal health system, so I have no financial disclosures of any kind. So what are we going to talk about? A brief tour, a brief history of sleep medicine. We'll talk about the neurophysiology of sleep, how much sleep we need, and why we sleep, and what is the impact of sleep deprivation on our health. To begin, let's begin with ancient India. And I begin with India for obvious reasons, but all cultures, all religions have something to say about sleep. But I'm focusing on India for one particular reason, is that the ancient Hindus had some keen insight in categorizing sleep. They describe the waking state, the heavens are in his head, fire in his heart, feet on the ground, the vibrant waking state, followed by the dream state, all right, which are no longer conscious of the external world, but only conscious of our internal objects and images. This then proceeds to a higher state of knowledge, and we're now no longer conscious of the external reality nor our internal world. We're in a state of total unity, in a deeper state of sleep. And finally, what is described as the highest level of knowledge in which there's total unity, in which we're totally unified with the divine. And this seems to resonate, in my opinion, with our modern notions of sleep, specifically wake, REM sleep, and non-REM sleep. All right, so I'd like to use this sort of as a springboard towards our modern interpretation of sleep. But on the way, let's stop off in the 18th century. It was known back then that all life forms, humans, plants, animals, exhibited behavior that varies with day and night. And this particular plant is called the heliotrope plant. The leaves, they open and close. They open and close. This plant can be entrained so that the leaves open in sunlight and close in darkness. This is what's called a circadian rhythm, where there's changes in behavior depending upon whether it's light or dark. And this is going to be particularly important in subsequent slides when I talk about the normal duration of sleep, how much sleep we need. Let's fast forward to the 20th century. Hans Berger was a famous German physician, and he invented what we know today as the EEG, the electroencephalogram. And specifically, here we have a schematic of a brain here. And let's zoom in on the cerebral cortex. All right? Underneath the cerebral cortex, all right, here's the surface of the brain. There are just billions and billions of nerve cells, beginning to sound like Carl Sagan, my hero. Billions and billions. So billions and billions of nerve cells here. And if we place an electrode on the scalp, we can actually record the microelectrical activity of the brain. And what Hans Berger found out, he showed changes in the brainwave frequency in sleep and wake. And this is a technology that we use today, looking at the physiology of sleep. In the 1950s, Kleitman and Azarinsky discovered what is called REM sleep. You have to take my word for it. This person has his eyes closed, so the schematic did not come out as ideally as I wanted. But what they noted is that during sleep, actually they looked at it in infants, that the eyeballs, with the eyelids closed, tend to dance around. They put some electrodes above and below the eye, and lo and behold, they discovered what are called rapid eye movements. So this is rapid eye movement sleep, or REM sleep. And we spend 80% of our time dreaming during REM sleep. Now, the 20th century, there was an explosion of scientific research in sleep. Rather than bore you to tears by going through every one of these, this will take the entire lecture time, and I don't want to face the irony of people falling asleep during a sleep lecture. Taking the advice of my father, you got to do a couple of things in your lecture. You either have to tell a joke, which I've done, all right? You have to dazzle the audience or show them something cute. Let me start by showing you something cute, all right? For the longest time, we did not have an animal model of a particular disorder that I see in the sleep center, okay? I see patients with a disorder called narcolepsy. It is a horribly devastating disorder that affects about less than 1% of the population, in which patients have profound attacks of sleepiness. They suddenly fall asleep during the day, and they lose the muscle tone of their body. Their bodies just collapse. Okay? And up until the early 1970s, we did not have an animal model until a dog was discovered in Saskatchewan, Canada, that exhibited the behavior of narcolepsy. And that dog was taken to Stanford University, subsequently interbred. Now they have thousands and thousands of these dogs that have what is called canine narcolepsy. And I want to show you a video of this. So, Philip, if you can go here and click on that, and click OK. And let's just blow up the screen so everyone can see. This is a puppy dog, all right? And you'll see the puppy dog suddenly, after it's eating something, it's going to suddenly collapse. Look at that. Now it's going to run. This is called canine narcolepsy. And to this day, these thousands of dogs are where we are obtaining a lot of our information about the basic science of narcolepsy. What is actually the cause of narcolepsy? And it turns out that these dogs have a familial form of narcolepsy. Oh, we can close the video now. So, I owe my career and everything I do in part not to just any dog, but to a Canadian dog. Okay, but is that the single best contribution that Canada has given to us in the field of sleep medicine? No. Well, let's blow up the screen. And Dr. Roger Broughton is one of the first pioneers in sleep medicine. He established one of the first sleep centers here at the University of Ottawa. And my father did some amazing collaborative work with him in the area of EEG and the characterization of sleep. So before we end our brief tour of the history of sleep medicine, I just wanted to pay homage to Dr. Broughton, and also indirectly pay homage to my father as well, who did some cutting-edge work with him. Let's proceed with that baggage, what exactly sleep is. These are what are called PET scans. And a PET scan is a reflection of the metabolic activity of the brain. Our brains love sugar, all right? When you get hungry, the first thing that you want is eat something sweet. Why? Because your brain is craving sugar. And the brighter the brain is, the more sugar that it's eating. And during the wake state, the brain is really, because the brain is so active, is chewing up sugar, all right? But people mistakenly think that sleep is like death. Look at death here. There's no activity in the brain at all. And sleep is not like coma. This is what happens when many of you have undergone general anesthesia, all right? You're in a pharmacologically induced coma. This is what your brain looks like. This is not sleep. This is what sleep looks like, all right? It's slightly less active than the brain, but nonetheless, the bottom line of the slide is that sleep is a very active process, all right? It's not passive, it's a very active process. Specifically during REM sleep, our brain is very active, and it almost looks like the wake state. We can now quantify sleep, all right, doing what's called a sleep study or a polysomnogram. And what we do in the polysomnogram is do the EEG, thanks to Hans Berger. We look at the eye movements with the eye channels, thanks to Kleitman and Azarinsky. And we also look at the muscle activity as well during sleep. Now, this isn't the entire array of electrodes. There's a lot more. For some of you who've actually undergone a sleep study, I'm sure a few of you have, they just cover the body from head to toe with electrodes. But for the sake of simplicity, I just want to restrict it to these, okay? So, during the wake state, as I said, the brain is very active. We got really fast brain waves, okay? And our muscle activity is very high because we're actively moving around in the wake state. Followed by non-REM sleep, okay? The brain waves progressively slow down into this deep delta slow wave activity, and the muscle activity begins to diminish, okay? And lastly, REM sleep, the muscle activity completely goes away, okay? Our bodies are physiologically paralyzed during REM sleep. We shouldn't be moving when we dream, is the bottom line. And we have the characteristic rapid eye movements during REM sleep. Now I want to show you something quite bizarre. This is a patient who has what is called REM sleep behavior disorder. This is why I went into sleep medicine. This is a person who is not paralyzed during dream. He's actually acting out his dreams. So if we can click this picture, we can show the video. This person is dreaming right now. Look what he's about to do. There's movement of his hand here, movement of the whole body. He's dreaming. Now look what he does. And he's dreaming. This is a pretty devastating disorder because you can imagine what happens to these individuals. They can either injure themselves, or worse, they can injure their bed partner. So if they're dreaming that they're in a boxing match, they're going to start punching their bed partner. And we also know one more thing. This disorder, there's an increased incidence of Parkinson's disease as a consequence of REM sleep behavior disorder.
Are you done?
Yeah, I'm done. We can close that. So, this is what the normal sleep architecture looks like throughout the night. The first half of the night is dominated mainly by non-REM sleep. There's a bit of REM. It takes about 90 minutes for us to go into our first REM episode. But predominantly is non-REM sleep. And the second half of the night is REM sleep. In fact, about 20% of the night do we actually have REM sleep. So 80% is non-REM, 20% is REM sleep. How much sleep do we need? Okay, good question. Everyone says, well, it's got to be 7 to 8 hours, but why? And I'll tell you why. Remember I showed you the heliotrope plant. The leaves open and close with day and night. Just like that, our brains, our level of alertness is determined by sunlight and darkness. So during the day, we're awake, and during the night, we're asleep. So our circadian rhythm, our natural biological rhythm, our internal biological clock, this is what happens, all right? And all life forms, including your own pet dog or cat, will demonstrate this behavior. But unfortunately for humans, we don't have the luxury of just obeying our biological clock. We do have to stay awake sometimes at nights, all right? At a cost. We develop what's called a sleep debt. all right? The more you push yourself to stay awake, the more sleepiness basically develops. We call that a sleep debt. And when we combine the effect of a sleep debt and the drive to sleep from our internal biological clock, that magnitude, all right, it is what is called sleep pressure. Okay? So our pressure to sleep is dictated by our own internal biological clock and also the sleep debt. And that sleep debt varies with age throughout the lifespan. That's what determines how long we're going to fall asleep. So here, from birth into our adult years, the duration of sleep varies. But on average, among adults, it's about 7 to 9 hours. And it is based upon this tug of war between our sleep debt and our internal biological clock. Now, why should I sleep? Okay? We've understood the how and the what, but why should I sleep? So I recall, about 7 years ago, when my first child was born, I was taking care of him that night. At the same time, I was on call in the hospital, and I was studying for my board exams. Right? So, and every one of you can give me similar tales as well of sleep deprivation. And over a short period of time, that is fine. Okay? This is another example of people entertaining themselves playing video games, something that I would discourage young adults to do. All right? I think they should be sleeping instead of playing video games. But every one of us has encountered this. We've got social obligations of one kind or another. It is only when we sleep deprive ourselves on a chronic basis when there are disastrous health consequences. The first is the obvious, all right? If you don't get enough sleep at night, you're going to feel sleepy during the day. You're not going to be mentally alert. You're going to have difficulty with concentration, remembering things. And this is a report from the Center for Disease Control, just looking at a survey among several people, the impact of sleep deprivation. And what's the most worrisome is that 11% of them report feeling sleepy while driving. Right? And I can show you countless statistics of the rate of rise of motor vehicle accidents as a consequence of sleep deprivation. And I think that this should be somewhat semi-obvious to all of you, but I want to show you something now that is not so obvious. We begin with our stomach. Right now it is mid-afternoon, but coming close to, say, 5 o'clock, your stomach is going to start rumbling, your energy level is going to be down. And when that happens, your stomach releases a hormone called ghrelin. Okay? And what ghrelin does, it stimulates and promotes appetite. It makes you want to eat. And so you do eat. You eat until the fat cells in your body, they produce a hormone called leptin. And what leptin does is tells you that your body is full. And once your body is full, you then exercise, burn off that energy, and the cycle repeats itself. This is a really, really effective thermostat that evolution has given us. But what happens when we are sleep deprived? This is a very key slide that I want to show you. If we sleep deprive ourselves, okay, the leptin levels go down and the ghrelin levels go up. Also, when you're sleep deprived, there's an increased opportunity to eat. You've got nothing to do, might as well eat, right? So there's a greater opportunity to eat. The upshot of that is that will result in increase in hunger and increased consumption of energy-dense food. So sleep deprivation, all right, can contribute to an increase in weight. This is body mass index, which is a correlate of weight. It results in an increase in weight, a decrease in leptin, and an increase in ghrelin. And what is the upshot of all that? Sleep deprivation can contribute to the development of obesity. Or at least it is a contributing factor for obesity. It's not the sole contributing factor, but it is a contributing factor. That can lead to hypertension, high triglycerides, diabetes, and high cholesterol. and obstructive sleep apnea. Dilip, can we click on this arrow here? Unfortunately, we don't have the volume for this video, but take my word for it, all right? This person is not breathing here, all right? She's struggling there. Now suddenly she took a huge breath. If we had the video, I can show you that she's snoring like that, okay? And when she stops breathing, her oxygen level, we normally oxygenate in the 90%. Her oxygen levels plummet to the 50s. And I can tell you, our brains and our bodies cannot tolerate that for a long period of time. Obstructive sleep apnea will lead to worsening high blood pressure, heart problems, increased risk for stroke, and also importantly, daytime sleepiness, which will put us at risk for getting into a motor vehicle accident while driving. Also, the long-term cognitive impact, memory loss, dementia, depression. Okay, we can close that. So, this is the end result of all of this, all right? They come and see me, all right? The problem is that this is a growing patient population. We're having more and more obese patients who have sleep problems and sleep apnea. And I'll tell you this, there's never ever going to be enough sleep specialists to take care of this patient population. What has to be done is that we have to have more effective preventative health strategies to address the problem at this end. Not only with encouraging everyone to have a good night's sleep, all right, avoiding chronic sleep deprivation, healthy diet, healthy exercise. That's the only way we'll be able to reduce this patient population and reduce the consequences of sleep. So, as promised, I'm going to keep this short, and this is going to be my last slide, our take-home points. We've reviewed some key historical landmarks in the area of sleep medicine. Sleep is an active neurobiological process and can be categorized as REM and non-REM sleep. I've told you that the amount of sleep varies with age, and it is determined by our internal biological clock as well as sleep depth. And lastly, that sleep deprivation has deleterious health consequences, but especially it has an impact on weight and the consequences of weight gain. So my concluding remark would be is, of course, sleep well, but also stay healthy. Thank you very much. And now this is the Q&A section, and these are just some questions that you can put in your minds for food for thought.
Excellent presentation. Just want to mention, Shekhar, we had a session here on obesity, and we covered some of the points that you raised.
Okay.
We had a full session from the university on sleep apnea, and which you heard being mentioned. Some of these things, consequences of sleep deprivation leading to obesity, and I'm talking about obesity in this case, we have covered all angles of obesity from time to time, and I'll come back to that a little later on, but right now is the time for question and answers. Excellent presentation, and so open for discussion. Yes.
I have a sleep apnea condition,
Yes.
and I was told that you can get a surgery done,
Yes.
and I read on the internet, the success rate is maybe 10–15%, and the surgeon was so non-committal. When I asked him to get a cure, and he said, could be, I said 50%, maybe. He was totally, didn't want to commit himself, and I canceled my appointment. He said, I can do it right now and charge you $3,000 with laser surgery or free with the OHIP. And I said, if I'm not going to get cured, what's the reason?
Yes.
And then he
Yes.
gave me the downside, that your accent will change, you won't be able to say and all that, and the sissy. And I use sleep apnea machine, it really is helping.
Yes.
I want your comments on that.
Absolutely. CPAP therapy, what is called continuous positive airway pressure. That is a device that patients with sleep apnea wear at night. It's essentially a mask that goes over their nose or mouth, attached to a hose to a machine that delivers air to keep their airway open. Because with sleep apnea, the airway keeps collapsing. And by forcing the air down, that keeps the airway patent. Now, that is the standard of treatment for sleep apnea. There is surgery. The downside, and what they do with surgery is essentially they remount all the redundant tissue in the back part of the throat to try and open up the airway. The downside of this is that there's only about a 30 to 50% success rate in treating sleep apnea with surgery. And that success rate goes down even further when the amount of sleep apnea increases in severity. That's one issue. The other issue is that this is the back part of your throat, and this is your palate. You know, if you look inside your mouth, you'll see this thing dangling down. That's part of your soft palate. The palate actually forms a barrier between your mouth, your oral cavity, and your nasal cavity here. And a consequence of removing this redundant tissue, you can see, is that you create a gap between your mouth and your nose. So that means that contents that you swallow won't necessarily just go down into your esophagus. Some of it will get refluxed into your nose. All right, so that's a potential complication of this surgery. So it is not surprising that many surgeons are reluctant to do this because there are adverse consequences of this. That is why the standard of care for treatment of sleep apnea is going to be CPAP and weight loss.
Yes, sorry.
I think the question and answer you put them there, they're so important questions. Why don't you answer them?
Is it okay to take sleeping pills? All right. Common question that I get asked in the sleep center. Doctor, can I get sleeping pills? Give me some Ambien, all right, so I can sleep at night. That's okay on a short-term basis, maybe for about 2 weeks. The problem with sleeping pills is in the long run, the effects wear off. Okay? You develop what's called a drug tolerance, where you have to increase the dosage of the medication in order to get the same effect. So it's a no-win battle. When you keep using it long-term, the effects are eventually going to wear off. And on top of that, when you stop taking the sleeping pill, you develop what's called a rebound insomnia. All right? Rather than taking the sleeping pill, it's better to actually treat the underlying cause of the insomnia. All right? I'm not saying sleeping pills are wrong, but just taking them on a very short-term basis.